Okay, I would like to invite Dr. Vikram Holla, Associate Professor of Neurology at NIMHANS, to tell us a little bit about Huntington's disease.
Good morning, everyone. At the outset, I would like to extend my gratitude to the HDSI and the organizers for inviting me here to deliver this lecture, or just to sort of introduce you towards what is Huntington disease. The patients and the caregivers may be knowing a bit better than me sometimes with respect to the symptoms and how to deal with it. So, me being a clinician, I'll be focusing a bit more on the manifestations, what all different manifestations there can be, and what are the treatments that we usually offer, and what are currently being sort of in the pipeline, so which we can expect hopefully in the near future. So, you want me to speak in other languages also, ma'am, or anything? Yeah. So, I can speak in Kannada and Hindi. So, if anyone wants to, I'll definitely speak in English. In addition, if anyone is there who cannot understand English, I'll be talking in simpler terms. So, it will not be very difficult. If someone wants me to speak in Kannada as well, please raise your hand. ಕನ್ನಡದಲ್ಲೇ ಇಂಗ್ಲೀಷ್ ಯಾರಿಗೆ ಬರೋದಿಲ್ಲ, ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡಿ ಅನ್ನೋರು ಇದ್ರೆ ಯಾರಾದರೂ? ओके एंड हिंदी में ही बात कीजिए. हमें इंग्लिश इतना नहीं आता है, हिंदी में बात कीजिए, ऐसा कोई है तो ओके, ठीक है. देन इट इज़ जॉब ईजी फॉर मी. So so coming to the presentation, as you can see, this is a shared presentation with Meera ma'am will be talking on the genetic aspect later on, and so if I miss anything in the beginning, I have ma'am to cover it up. So going to the Huntington disease, so it is as already mentioned earlier, it is a chronic disease, goes on for years together, before the onset of symptoms and after the onset of symptoms, and it is an inherited brain disorder, so it is familial, hereditary, and specific part of the brains are affected, and other than brain, there are very few manifestations that can affect, and those also predominantly because of the linkage to the brain, and usually begins in adulthood, but there are patients who are in their early 20s and late 20s as well who have developed this disease, and it is mostly comprising of movement abnormalities like either excess movements or reduced movements, cognition or memory, and the other cognition like planning, execution defects, and also emotion and behavioral abnormalities can also be there. So just briefly, in 1872, the first description of Huntington disease, that time it was called as hereditary chorea, familial chorea, was described by George Huntington by observing his father's and grandfather's patients. He had a very long, he had an advantage of observing families of this disease, and he wrote this paper describing, and almost many of the description holds true even today, and including the juvenile onset Huntington disease and all. Within 10 years, the chromosome 4 was identified as the region where this particular gene is situated. However, it took almost a century to identify the particular gene. So you can see sometimes some of the advances happen quite quickly, and there is a long latency period. So it is a non-linear sort of latency we can see. So symptoms of HD, as I mentioned, it is predominantly 3 domains. So movement, abnormal movement, where I, being a neurologist, usually manage the patients for these symptoms. Then there is cognitive symptoms, where whenever we say cognitive, or many patients come and tell us, I don't have memory issues, I don't have, the colloquial term for dementia is only memory impairment. But there are various other domains that are affected in cognitive impairment, and also psychiatric. So coming to the motor symptoms, most often, we would associate Huntington disease with chorea meaning dance-like movements. So they will not be sitting stiff. They'll be continuously moving, not able to control their involuntary movements. Initially, they may look like very fidgety. Why are you not able to stand straight? Why are you fidgeting too much? So these movements can also sometimes, this is the most often seen movement in Huntington's disease. There are other abnormal movements also, which we call it as dystonia, which is abnormal posturing. There will not be a slow dance-like movement, there is just a sustained posturing of the body can be there. And later part of the illness, more and more disease progresses, the movements decrease, and so much so that there is no voluntary movement as well. The patient will become rigid, stiff, requiring almost continuous care by the caregivers. In addition to that, there is gait abnormalities. It looks like they are going to fall, and many patients do have falls at the later part of their disease. And there is also difficulty in speech and swallowing. I mean, which is again, one of the very basic requirement of a person. But that also gets affected with respect to speech, not able to pronounce properly. Later on, not able to speak or vocalize. Also, the sound also may become difficult later on. And almost simultaneously, there is also swallowing difficulty, repeated choking. So these are the movement-related abnormalities, including eye movements. And then cognition, as I mentioned, memory may not be that much affected in the beginning. It is more to do with the frontal lobe, which we call the front part of the brain, which controls the planning. So if at all I have to come to this particular conference, I have to plan in the morning or maybe weeks before that I'm going to go to this conference, I'm going to go by this road or this route, I'm going to do this. And so this all planning is essential for us to go have a good quality of life. So the decision making, planning, and lack of insight. Many times say he doesn't know how to behave with the relatives. I mean, it is not the conscious. It is subconsciously the person is not able to understand at how to behave. I mean, it is not that voluntary being done. It is it is beyond the patient's control. And similarly, there may be rigidness, getting stuck to one particular point and not listening to others. So these are all manifestations of the disease rather than patient doing it out of insight. Then there is behavioral abnormality like both depression, anxiety, apathy, aggression, irritability, and impulsivity, going to do certain things repeatedly. So all these features can be seen as a manifestation of Huntington's disease. If a patient develops this behavioral abnormality first, they tend to go to psychiatrists, and later on when they develop other movement disorders or memory impairment or cognitive impairment, they were referred to us. If the patient develops movement abnormality first and the memory impairment or the cognitive impairment first, they tend to come to us first, and we will be referring. Whoever the patient approaches first, we always make sure that they go to the other specialist, because there may be some subclinical. The patient may not have noted that. The relatives may not have noted that. So still, whenever the patient of HD comes to me, I always make it a point that I refer them to psychiatrists so that they can evaluate and see is there any subtle changes in the psychiatric symptoms which can be managed with medications. Then apart from that, there is also sleep abnormality, pain. Many times patient complain of pain because of it may be depression or the movements, and also nutrition abnormality, weight loss can happen, dysphagia, and inability to absorb the nutrition properly. So these all features also can happen in patients. And coming to what causes Huntington disease, you may be aware it is a genetic disorder because of the Huntington gene. And basically what happens in the gene is already, a very lucid talk was given by Srini in the morning, where he described, there is an increased repeat. Usually there is number of repeats, 10 to 26 repeats is normal, where the patient will not develop disease at all. Then there is 27 to 35, where the person will not develop the disease, but it can increase in the subsequent generation. This person will not develop the disease, but the person's children, especially if the father transmits this particular repeat to the children, the children may develop the disease. And this is where many times patient comes to me and say, I have read that it is an inherited disorder, my parents doesn't have it, how come I am having it? So this is where, the sporadic or, without any family history, which can happen in 5% of the Huntington disease patients. So, and also there is incomplete penetrance, where the patient may say, I have the disease, my brother doesn't have the disease, but the brother's son has the disease. So how come it is skipping my brother? So it is incomplete penetrance. So when the range of repeat is in 36 to 39, so some patients only develop the disease and some patients may not develop the disease. And this is a good, in the sense we need to understand why this happens, why all doesn't develop the disease, and maybe we can potentiate that protection factor that is there in those patients those people who don't develop disease in this range. Then there is fully penetrant, that is beyond 40 repeats. It is just matter of time that when you develop the disease, but if you live long enough, you are going to develop the disease. And also it is autosomal dominant, that 50% chance. Dr. Meera will explain what is this 50% chance of developing the disease in her talk. And then also the other thing that patients do come to us and ask is the anticipation, where the patient says that my father had it at 60s. I am still 30, 35, 40 years old. Already I am having the disease. So there is the sort of a feature seen in Huntington disease and many of the repeat disorders, which is Huntington disease also one of the type, where subsequent generation is going to have them at earlier and earlier. So that is the unfortunate thing about the disease, that subsequently sometimes it has also happened the parent has not yet developed the disease, but the child has developed the disease, and the parent is going to develop the disease in the future. So those instances are also there. And also the number of repeats up to a certain extent decides what is the age of onset. And there are also instances where the patient has come, I have HD, I know, but my son is also having some symptoms, but it doesn't look like what I have. He is very rigid and stiff. He is not able to make any movements, whereas I am very hypermobile and I am making lot of movements. So it is not the same. It is not what I have. But then what happens in the juvenile HD, sometimes the patient may not have chorea. They may have a different manifestation. Juvenile is when the patient develops the disease less than 21 years of age. So same disease can have different manifestation, and it just depends on the number of repeats. And this all Dr. Meera is going to describe in brief. Basically, in the morning also it was mentioned there is aggregation which may damage the cells, neurons in a different ways. And when the patient comes to us, most of the time we know it is HD based on the clinical evaluation itself. Any patients who come with chorea with the family history is more often than not HD. But still, we need to do the assessment, look for any other cause that may look like Huntington disease, do an MRI and see what is the pattern of abnormality that is there. And finally, we go for genetic testing, because many times what happens, the patient may come for some symptom and say, I have a family history of HD, and we get a genetic report that he may be positive. The symptom may be something else, and we attribute everything to HD, and we may not look for the alternative cause. In a body, there may be 2-3 diseases. So it is not that if just because a disease is there in a family, it has to be the same disease. And if not HD, there are various other illnesses that can mimic. And once the diagnosis is made, usually first step is counseling. I mean, what it means to the family, the patient, caregivers, and symptomatic treatment where there are various medications, mostly for the control of the symptoms, and also evaluating additional subclinical deficits. As I mentioned, the patient might have come to me as a movement disorder, but there may be some subclinical psychiatric symptoms which I have to take care of. And multidisciplinary support is one of the most important thing in Huntington disease, because there are various other manifestations apart from neurology, psychiatry. And also facilitating support groups. I think HDSA is one of the example where the support group and the advocacy may help in going a long way. And also enrolling into any novel therapeutic options if at all available in the center. There are various medications, but unfortunately all of them are being given in the symptomatic individual. Hopefully we'll have a lot of interventions where we can do even before the symptom starts or at the very early stage. And hopefully there are various trials that are going on, and hopefully some of them at least will reach its fruition, and hopefully we get to see treatment where we can prevent the progression rather than just managing the symptom. And to conclude, it is a progressive disorder. We know a lot, but still there is a lot that we do not know, and we need to work on it. And even though it is incurable, but still there is a lot we can offer to the patients and the caregivers if they come to us and we engage with them. And also there are novel therapeutic options that are in the horizon, and we hope that we get them. So this is our team at NIMHANS Neurology, and also I thank Meera ma'am and Biju sir, Sanjay sir, with whom we collaborate for patients with Huntington disease. Thank you.
Thank you so much. Now I would like to invite Dr. Meera Purushottam, senior. Oh, sorry. We would just like to give you a small token of appreciation.
Thank you. Any opportunity giving 2 questions?
So, yeah. We'll do questions after Dr. Meera's talk. She will talk about the genetics behind Huntington's disorder.
Hello, everyone. I know many of the talks have already mentioned what happens and what is at the genetic level, but I thought I would just break it down a little more for people who find it difficult to comprehend when it becomes too technical. So, what is Huntington's disease? Something has happened here. Sorry. Yeah. So, what I was planning was to put it up in English and speak in Hindi or Kannada. If there is Is there anybody who cannot understand English? ನಿಮಗೆ ಇಂಗ್ಲೀಷ್ ಅರ್ಥ ಆಗ್ತಾ ಇದೆಯಾ? ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡೋದು ಬೆಟರಾ? ಆಯಿತು. I will speak both. Okay. So I have put the steps in English. So मैं आपको बताना चाहती हूँ कि जब लैब में ब्लड सैंपल लिया जाता है उसके साथ क्या होता है, हम क्या टेस्ट करते हैं एक्चुअली. अभी पहले तो ये है कि हमारे खून में बहुत सारे डिफरेंट काइंड्स ऑफ सेल्स होते हैं. उस सेल्स में डीएनए नाम की चीज़ होती है. अब हमारे सेल में बहुत सारे प्रोटीन्स हैं और ये जो डीएनए है ये एक तरह का कुक बुक मान सकते हैं आप. तो ನಮ್ಮ ರಕ್ತದಲ್ಲಿ ಬಹಳಷ್ಟು ಬೇರೆ ಬೇರೆ ಸೆಲ್ಸ್ ಇದೆ. ಅಂದರೆ ನೀವು ಕೇಳಿರ್ಬೋದು ವೈಟ್ ಬ್ಲಡ್ ಸೆಲ್, WBC, ನಾವು ಬ್ಲಡ್ ಕೌಂಟ್ ಮಾಡುವಾಗ ಬೇರೆ ಬೇರೆ ಥರ ಸೆಲ್ಸ್ ಇರುತ್ತದೆ. ಸೊ ಇವಾಗ ಈ ಪ್ರತಿ ಸೆಲ್ನಲ್ಲೂ ನ್ಯೂಕ್ಲಿಯಸ್ ಅಂತ ಇರುತ್ತೆ, ಅದರಲ್ಲಿ DNA ಇರುತ್ತೆ. ಇವಾಗ ಈ DNAಯಿಂದ ಸೆಲ್ಗೆ ಗೊತ್ತಾಗುತ್ತೆ ನಾನು ಏನೇನು ಮಾಡಬೇಕು, ಯಾವ್ಯಾವ ಪ್ರೋಟೀನ್ ಮಾಡಬೇಕು, ಎಷ್ಟು ಮಾಡಬೇಕು ಅಂತ. ಸೊ this is basically the cookbook. So what does the lab do? The lab is going to look at finding the recipe for the Huntington protein. So the protein, Huntington is the one that's the problem, as we all know in Huntington's disease. And within our DNA, there is one part of the chromosome that gives instructions on how to make this protein. So this is just a small picture I've put of the cell, and this is a nucleus, and these are all the chromosomes. Now the DNA is a very, very long thing, and it's negatively charged. So it is nicely wrapped up and made very tight and compacted and put inside the nucleus. So whatever part is needed is made loose and expressed, to put it very, very simply. So there are, as you know, many chromosomes. There is chromosome 4, which actually codes for this Huntington gene. And in this, if you see, as we know, the DNA is made up of 4 bases, A, T, G, and C. So there is a sequence of CAG, which is repeated many times in this Huntington gene. And DNA codes for protein. So this cartoon here is showing you a cartoon of the Huntington protein. So this CAG codes for this red part, which is the glutamine stretch in the Huntington protein. So if you have a normal stretch, so ये जो है ये DNA मॉलिक्यूल है आपका, और ये ऊपर है ये प्रोटीन है. जब सब बता रहे थे कि 36 से अगर कम है तो कोई प्रॉब्लम नहीं होता है, तो ये वो प्रोटीन है जो ठीक से काम कर रहा है. जब ये CAG बढ़ जाता है और 36 से ज़्यादा हो जाता है, तब ये जो आप देख रहे हैं ग्रे पार्ट, ये ज़्यादा लंबा हो गया इसमें. तो ऐसे होने से ये प्रोटीन अपना काम ठीक से नहीं कर पाता. तो ಆವಾಗ ಈ ಪ್ರೋಟೀನಿಂದ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ಲಿಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ ಆ್ಯಂಡ್ ಪೇಷಂಟ್ಗೆ ಪ್ರಾಬ್ಲಮ್ ಶುರು ಆಗುತ್ತೆ. ಸೊ ನಾವು ಲ್ಯಾಬ್ನಲ್ಲಿ ಏನು ಮಾಡ್ತೀವಿ, ದಿಸ್ ಪಾರ್ಟ್ ಆಫ್ ದ ಜೀನ್ ಇದನ್ನು ನಾವು ಆ್ಯಂಪ್ಲಿಫೈ ಮಾಡ್ತೀವಿ. ಅಂದರೆ ತುಂಬ ಕಾಪೀಸ್ ಮಾಡಬೇಕು, ನೋಡಲಿಕ್ಕೆ ಇದು ದೊಡ್ಡದಾ ಚಿಕ್ಕದಾ ಅಂತ ನಾವು टेस्ट ಮಾಡ್ತೀವಿ. तो इसका साइज़ जानने के लिए हम इसके बहुत सारे कॉपीज़ बनाते हैं. तो जैसे आप ज़ेरॉक्स मशीन के तरह PCR मशीन नाम का एक इंस्ट्रूमेंट होता है जो उस DNA को काफ़ी सारे कॉपीज़ बना देगा. तो इस मॉलिक्यूल को अब हम लैब में एक और इंस्ट्रूमेंट में चलाते हैं, जिससे पता चलता है कि ये ठीक है या इस पेशेंट को प्रॉब्लम है. तो जब ये साइज़, जीन का साइज़ बहुत बड़ा हो जाता है, तब हमें यहाँ एक, जैसे आपको दिख रहा है, एक काफ़ी सारे ऐसे पीक्स ऐसे हो जाता है. तो ये हमें बता रहा है कि ये इस पेशेंट को हंटिंगटन्स होने की साध्यता है, क्योंकि इनका जीन काफ़ी बड़ा हो चुका है. तो इससे क्या प्रॉब्लम है, जैसे पहले टॉक में बता रहे थे श्रीनी, कि जब ये प्रोटीन का ग्लूटामीन सही है, मतलब लिमिट्स के अंदर है, तब ज़्यादा कुछ प्रॉब्लम नहीं होता. पर जब बड़ा हो जाता है तो ये बहुत स्टिकी हो जाता है और अपना काम ठीक से नहीं कर पाता है. तो ಈ ಟೆಸ್ಟ್ನಲ್ಲಿ ನಾವೇನು ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಎಷ್ಟು CAG ಇದೆ ಅಂತ ಟೆಸ್ಟ್ ಮಾಡಿ ನೋಡ್ತೀವಿ. ಸೊ ಜಾಸ್ತಿ CAG ಸ್ಟ್ರೆಚ್ ಆಗಿದಾಗ ಆ ಪ್ರೋಟೀನ್ ಸರಿಯಾಗಿ ಕೆಲಸ ಮಾಡಲ್ಲ. ಸೊ ಅದು ಸ್ಟಿಕ್ಕಿ ಆಗಿಬಿಡುತ್ತೆ, ಮತ್ತು ಸೆಲ್ನಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಕಡೆ ಅದು ಪ್ರೆಸಿಪಿಟೇಟ್ ಥರ ಆಗಿ ಕೂತ್ಕೊಂಡ್ಬಿಡುತ್ತೆ. ಸೊ ಇಟ್ ಡಸಂಟ್ ವರ್ಕ್ ಪ್ರಾಪರ್ಲಿ. So I'm just summarizing here for those of you who can understand. So like Dr. Vikram also mentioned, you have different ranges. So you have a fully penetrant allele. So if you have more than 40 CAGs, then you do have a positive report. So we have been doing this testing for about 10 years now at NIMHANS, and in our patients the mean range has been around 45, and the age of illness of these patients is generally around 40 years. So where is this Huntington gene? It is in chromosome 4, as we know, and it's a fairly large gene. It has 67 exons and 180 kilobases, and the protein has more than 3,000 amino acids. So it's a very big protein. Unfortunately, what exactly it does and why it is good or bad, its functions are not completely understood. What we do know is that's an extremely important protein. If it is not there in cell model organisms, the organism doesn't survive at all. So it is what you call an essential protein. So the cell cannot survive without this protein. We know that. There have been studies, in fact, where people have looked at cognition and such properties of traits in people who have had a slightly expanded allele, and they have shown that it is beneficial, in fact. So there's something that's very unique about this protein that is still not completely understood. So this is just another graph telling you what are all the sizes of the different repeats that we have found. So this darker one here is the normal repeat range, and this is the expanded repeat range. So this is a sort of a standard pedigree, I would say, of a HD family. So you can see here that the circles are usually, we represent circles as the women in the family, and the squares are the men. So you can see that this couple here have so many children, but not all of them have inherited the disease. There may be some who have and some who haven't. Here, for example, this gentleman who has not inherited the disease has children again who are all fine. So what happens? So there is something, this kind of inheritance is called autosomal dominant inheritance. इसका मतलब क्या है? ये आपने ये टर्म सुना होगा शायद. तो जब ये जो फिगर है इसमें आप देख रहे हैं कि एक महिला, एक स्त्री और एक पुरुष दिखाया गया है. तो जब हम हमारे डीएनए में अगर आप देखेंगे तो हम हर टाइम एक कॉपी हमारे माँ से आती है और एक दूसरे पिता से आती है. तो ये जो दोनों है इनके मम्मी और पापा का यहाँ डीएनए दिखाया गया है. और ये जो ब्लू कलर में दिखाया है ये प्रॉब्लम, या आई डोंट नो व्हाट टू डू. This one, huh?
You just click on this button.
Yeah, I don't know. Is it visible?
Yes.
Okay. So I think it's fine.
Okay.
You can continue.
Yeah. So as I was saying, यहाँ आप देख रहे हो ये जो ब्लू कलर है ये म्यूटेटेड जीन है, मतलब इनमें CAG एक्सपेंशन है. तो जब इनके बच्चे होंगे, अगर अब देखेंगे तो एक कॉपी उनके माँ से आएंगी और एक उनके पापा से आएगी. Leave it, it's okay, I'll manage this. So ये अगर ब्लू कलर के ये फादर है तो इनके ये भी क्रोमोसोम जा सकता है बच्चे को और वो नॉर्मल भी जा सकता है. He is moving the cursor.
Yeah. Double control.
Okay, it's fine. I just continue. तो यहाँ क्या हुआ है कि अगर अगर बच्चे को ये वाला अच्छा वाला क्रोमोसोम आया है तो बच्चा ठीक रहेगा, लेकिन अगर ये ब्लू वाला क्रोमोसोम आने से बच्चे को प्रॉब्लम हो सकता है। तो इसी तरह से अगर आप तो 4 डिफरेंट कॉम्बिनेशंस पॉसिबल है, तो इसीलिए बताया जाता है कि 50% है चांस कि आपके बच्चे को एचडी हो सकता है जब आप काउंसलिंग के लिए जाते हो, क्योंकि ये जैसे आप देखते हो 4 कॉम्बिनेशन पॉसिबल है, क्योंकि अगर इनसे ये वाला क्रोमोसोम 2 बार जा सकता है और ये वाला 2 बार जा सकता है, उसके वजह से ऐसे इनहेरिटेंस होता है। So, one more thing that Dr. Vikram mentioned is something called as anticipation. So, we have often tested families where we have tested the parental generation and the offspring generation. So, this here shows the upper allele size, and these are different families that we have tested. Sometimes the parent and offspring may have the same allele size, but sometimes there is a jump. So there is an increased allele length in the next generation. So why does this happen? This happens because you remember I was talking about CAG. So CAG is a sequence that by nature is a little difficult to manage for the system. So sometimes there are these kind of looping outs that happen, and in the process of correction, the system adds another error. So I just want to switch a little bit now and talk about the brain pathology. So I'm sure many of you have seen this image. There are different parts of the brain that gets affected in Huntington's. So recently there was a very interesting paper that showed that even in the brain, though when we do a blood test, we see a certain CAG, let's say 36. As the person ages, the number of repeats in different brain regions keeps increasing. And at one point, it can become so high that the neurons are not able to handle it, and the neuron dies. So this is actually called as somatic mosaicism. So here this is showing the same thing. So when you at 100% you have, at birth you have all the neurons intact, and slowly over time it goes away. So people have shown now that when the CAGs become higher than a certain size, that is when the symptoms are very acute and the patient's condition deteriorates. So this happens because during DNA replication and etc., there is out of register reannealing. So because of the CAG being such a difficult sequence to manage, there are other proteins which are on alert, and whenever they see a loop like this, they get triggered into action and try to repair the situation. Unfortunately, the process of repair actually causes an increase in the number of CAGs. So this has been shown in using postmortem brain tissues of a large number of people who were in different stages of disease, and they have shown in mouse model systems that if you interfere with these proteins that are involved in repair, it actually helps the situation and the repeat size does not increase too much. So we were very fortunate to have a brain donation here by a HDSI member, and so we have a Huntington's disease brain in our brain bank, and we try to ask the same question here. So you can see this is the cerebellum and this is the frontal cortex. So what we found is that in the cerebellum there is very tight control and you don't see too much of expansion, whereas in the frontal cortex there seems to be a lot of slippage, and we find a very large number of peaks that keeps going. We were also curious to see what happens in the skin and muscle, because these are also dividing tissues, and especially in the muscle we know that in HD there is a lot of movement, so we are curious to see what's happening. But our preliminary results are showing that the skin and muscle don't seem to be showing much of a stutter, but the frontal cortex does show. We are now taking this to the next level. We want to do cell-specific gene expression and see whether There are particular kinds of cells in different parts of the brain that have different lengths and different gene expression because of which this happens. People are seriously thinking of this as a treatment option because this may not cure HD, but it would postpone the very severe symptoms for very long. So just like you take medication for diabetes or something, if you could take something to keep your DNA repair machinery at bay, probably you will not find HD to be such a terrible disease. So let us see where science takes us. This is another work that we have done in our lab some years ago. So the ends of the chromosomes also have a repetitive DNA. This is a hexanucleotide repeat that is repeated several times. And we found that in Huntington's disease, the telomere length is significantly lower. With that, I will end. All this work was possible because Dr. Jain started all of this, and I must say that there are various students and technicians who've been doing DNA isolations, collecting blood, doing all the hard work that goes into doing reliable DNA testing. And these are all the collaborators from Neurology. Thank you. We'll now take questions. Anybody has anything to ask?
Right. Good afternoon, ma'am. If one of the parents is affected with Huntington's disease and they have 4 kids, so is there a chance that only one kid is affected from the disease and 3 are not?
Yes.
Or will it be like 50% of the children will be affected?
No. So it is a 50% probability at every pregnancy. So a family can either have all 4 affected, God forbid, 1, 2, 3, 4. There's no rule like 50%. When we say 50%, we don't mean that if there are 4 children, 2 are going to get ill. No, that is not what we mean. What we mean is that at conception, at every pregnancy, there is a 50% chance for that individual. That's what I was trying to explain to you. It depends on which combination of chromosomes that particular individual has inherited from the parents. If they have inherited the faulty chromosome, then they are going to get sick. And because statistically there's a 50% chance of inheriting a faulty chromosome, we say it is 50%.
Right. Okay. Thank you.
Yeah, ma'am, I want to know that is there a direct relationship between number of CAG repeat and the starting age, symptom starting age? Because in my family, I have experienced that like my father has experienced in somewhere around 30 years of age. But their onset are, their problem is being identified at the age of 20 to 25.
Yes, so there can be a lot of variation. Very broadly, there is an inverse relationship between the CAG repeat length and the age of onset. That means higher the age of onset, higher the repeat length, earlier is the age of onset. But this is a very broad rule. Besides this, it is the other genes which you have inherited from, let's say, your mother and the other genes in your father, and plus your quality of life, what you have been doing, how you have lived your life, etc. So it is very difficult to predict right now, but it is definitely not like 100% thing that if this is your CAG, this is when it's going to start. It's a very broad approximation. So I will show another slide later in the next talk, which will tell you that it is really something that one can possibly try to work with and improve and postpone by doing things. So that's what we are trying to do through the registry to improve awareness.
I am positive Huntington. I have two children. So, as per this theory, there are 50% chances of one getting HD. Suppose by grace of God, they did not get HD positive. Will my grandchildren are likely to get HD?
No, sir. So to clarify again, if you have two children, it is not, when I say 50%, I don't mean that one of your children will get sick. It may be that both of them are going to be fine. And if they are going to be fine, their children will definitely not get it. So you don't have to worry about that.
Thank you. Thank you.
There are no mics now. Ask some students.
I have, good morning all. I have two questions. One is about HD being, is it gender specific? It is clearly mentioned 50%. Is it gender specific? Like my mother had HD and dementia, and my sister is having HD. So is it like gender specific? Is it like the next generation?
No,
May
it
not-
is not at all gender specific because the Huntington gene is on an autosome, so it is irrespective of gender. So men and women are equally at risk. So there's nothing like if it is a lady, the daughter is going to get, or any of those things. Father or mother can pass it on to son or daughter equally. There's no such proportion.
Oh, thanks, madam. Second question on the hope of Huntington's care, like past 10 years, okay, what is the hope for the Huntington's patients? Like, it is still at a research stage.
Yeah, and as I was mentioning, unfortunately, the advances that happen doesn't go in a linear way. Sometimes we get something new very immediately, and thereafter the next thing will come after many years. Unfortunately, with respect to the good thing is there are a lot of studies in different ways being done to see not only the medication in whatever, like Meera ma'am was saying, there is a new strategy of stopping the abnormal correction that is happening in the not only the gene. We will go through a different manner. But as of now, I mean, apart from the medications and supportive care, that is for symptomatic therapy, unfortunately, we have not been successful in providing any treatment that can delay the progression, slow the disease, or cure the disease. But there are lots and lots of studies that are going on, and hopefully, I mean, at least a few of them will have a few of them will be successful. So ऐसा है कि मतलब अनफॉर्चुनेटली क्या होता है कि मतलब कुछ स्टडीज बहुत ज़्यादा हो रहे होते हैं. 100 स्टडीज अगर हो रहा है तो उसमें से एक या दो सक्सेस होके ट्रीटमेंट में निकलता है. तो 99% ऑफ द स्टडीज जो होता है वो स्टडीज में अच्छा रिस्पॉन्स आता है, लेकिन जब पेशेंट में वो वही दवाई दिया जाता है तो उतना अच्छा रिस्पॉन्स नहीं आता है. तो अभी फ़िलहाल बीमारी को सिम्टम्स को कंट्रोल करने के लिए दवाइयाँ हैं, फिजियोथेरेपी, स्पीच थेरेपी, ये सब है. लेकिन बीमारी को आने से रोकने के लिए, आने का टाइम को डिले करने के लिए, या फिर जब आ गया उसका गति को स्लो करने के लिए फ़िलहाल कोई भी मेडिकेशन या ट्रीटमेंट अवेलेबल नहीं है. बहुत सारे स्टडीज़ चल रहे हैं, एंड अभी हाल फिलहाल में बहुत सारे कई सारे कुछ जेनेटिक बीमारियों के लिए भी ट्रीटमेंट आ रहा है. ऐसे ही हंटिंगटन डिजीज के लिए भी ट्रीटमेंट आए, ये हम आशा रखते हैं.
Thanks.
Then now?
Yes.
Yeah. And the other one is like, is it any clinical research is happening in India, or somebody want to participate? Indian patients, is the way forward is there?
No, I mean, treatment in NIMHANS, I mean, the therapeutic trial is not happening. Again, even in the Western population also, none of them are in the sort of phase 3, phase 4 where the benefit has been observed. It is most of them are phase 1, phase 2 trials where the safety and proof of concept is being done. So that's what in India. I mean, usually whenever there is at least in phase 3, phase 4, it will be brought to India also. So that stage, unfortunately, none of the medications have sort of reached. There are medications like in the sense which are for symptomatic treatment. Like we have tetrabenazine. There are other medications like deutetrabenazine, valbenazine, which are available abroad but not in India. But then they don't. Offer the thing that they can offer is not that. Too much compared to tetrabenazine. It is almost similar to tetrabenazine, dose difference, side effect a bit difference. So it is not like you are missing out on something by not getting these medications here. Therapeutic in NIMHANS treatment trials are not happening. Clinically, we are doing certain, this one you can just...
One.
Sorry, we will take the questions after some time, and Dr. Meera would be around for you to ask questions. Okay, fine.
Just one question was regarding a revoke on medicine. So, can we start a revoke on medicine for a patient for juvenile stage?
So, as you should understand that these medications are just for the external symptoms. So, whether you take the medication or not, the disease is not going to have any, the medication is not going to have any bearing on the disease. So, and every medication comes with its own side effects. There is no medication that doesn't have side effects. Fortunately, the side effects doesn't happen in everyone, but it can happen in anyone. I may take the medication out of 100, only 1% may develop side, but that one may be me. So what we do is, we will ask the patient, this particular chorea, how much disabling is it for you? Do you feel it is bothering you in the sense that you are not able to do any activity? If the patient says, I notice this, but more or less it is not bothering me, then we say, okay, let us wait and see. When it is bothering you, that time we will start the medication. Whether you start the medication today or a year later or 2-3 years later, the disease is not going to change the course. So it is not like you delay the medication, the disease will progress faster. So doctor, start it today only, why you are waiting for it to increase? It is going to increase if it has to increase, despite you take the medication or not. So because as Professor Pal mentioned in the morning, judicious use, whatever medication we have, and there are many other medications that may interact. I may give some medication, psychiatrist may give another medication. Unfortunately, they all have some interactions. So what we want to do is, our dictum is do no harm. So first of all, I want to say that the medication I'm going to give is going to benefit the patient or may harm the patient. If I feel the benefit is way more compared to the harm, definitely I'll discuss that with the patient and then we'll go ahead with that. If I feel the benefit may be less but the harm is more, then I may not discuss the medication itself because I know that the harm may be more. So that is, it is not necessary that you have to take it. As and when required, we'll prescribe it.